Well, hello and welcome to this event where we're considering moves towards a more integrated care model for people living with non-communicable diseases, NCDs. This is the second webinar organised by FPIA Diabetes Platform and the European Diabetes Forum, EUDF, investigating the syndemic threat of COVID-19 and chronic diseases. On the meaning of syndemic more shortly. My name is Sue Saville. I was the medical correspondent at Britain's ITV News, and I'm delighted to be back for this second webinar, having considered at the first, which was back in May, the role of health data registries, European health data space. And now today, we're looking at integrated care models, how they can help member states to better protect the health of vulnerable communities, such as those living with diabetes, both in crises and of course beyond. And this is very timely this week, which marks World Diabetes Day. The event is being recorded and it will be made available later. We do very much want your involvement, so thank you so much for joining us. Do put your questions in through that Q&A button on the chat function, on the Q&A function there. There is a chat function. That's in case you had any contributions you'd like to make, just general comments, or if you have any technical issues, do flag them up in the chat. We're going to have 75 minutes together, and in that time we have 2 panel discussions and also a presentation on some of the latest research into the value of integrated care. But first, it's my great pleasure to hand over to Dr. Javier Cost, who is the chair of Primary Care Diabetes Europe and also an EUDF board member, to tell us more about today's topic. Javier. That's that mute button, Javier.
Thank you very much, Sue, for your kind introduction. And yeah, I'm here now with connection. Okay, so I think it's important, and I think it's realigned with what's going on in the real life at the moment. I think integrated care is something that we have all the healthcare systems across the globe. We have to be very concerned and provide the importance for that. I think it moves us to the concept of synergy or syndemia. Syndemia, I think, is a concept where we have to consider that different epidemics are together and they have some interaction between them, and there are social determinants. There are also interaction between different diseases, and that makes that this disease or this concept makes that the problem will be bigger and it requires attention from different channels or pillars. In terms of the COVID on this, I think it was the Lancet, and at the moment he's Richard Horton at that time, who consider that COVID-19, it means pandemic, it was also part of a syndemic process at the moment, because it was other chronic diseases as obesity, as diabetes, and others that, and also these social determinants I mentioned before, that also could be crucial in terms to understand what could be observing across the globe about this situation of the COVID and the other diseases in this syndemic aspect. For this reason, I think an integrated care approach is mandatory. We have to be very organized, and also according how the healthcare service is organized in each country, probably provide that changes, that adjustments, that put in context, and also considering moving on taking care of the COVID as a disease, but also the other chronic diseases at the same time we see, and worsening and increasing of that chronic problems at the same time we observe the COVID-19 pandemic. So with this intro, I think it provides sense to this session today organized by FPIA and EUDF. I think it's a moment that we introduce the panels and the speakers to start providing their presentations. So I move to you again, Sue, and thank you for your intro to provide my point of view and my vision. Thank you.
Javier, thank you. And I know we will be speaking with you a little bit later in this session. But first to our first panel, and I'd like to introduce the 2 speakers who are going to consider Rethinking Future Crisis Preparedness from a Syndemic Perspective. So I'm delighted to welcome Philippe Domansky. He is a policy officer at the European Commission, and also Joachim Ramsberg, project director at the Swedish Agency for Health and Care Services Analysis. Gosh, so Javier has set the scene a little bit for us there. Perhaps we should just define integrated care, what it means for chronic non-communicable diseases. Philippe, would you like to take that? Could you define the context?
Thank you, Sue. Good morning. Thank you for having me. I wouldn't say that integrated care from point of view of patients with chronic diseases is different than integrated care for patients from point of view of patients with acute problems, even though indeed integrated care works much better, if I may say so, in case of chronic diseases. Or this concept appeared in the discussions as a response to rising burden of chronic non-communicable diseases. Generally speaking, it means that all the actors engaged in providing care, not only healthcare, this is probably also important that we are talking at least about integration of health and social care, that all the actors who are engaged cooperate, that they put patient or person, in the center. And in practical terms, what does it mean? For example, that if you go to a GP and the GP suggests you to go to a specialist because you might have some specific problem, then first of all, you learn from the GP where to go exactly. Also, information about your condition travels with you or along you to the specialist. Then when the specialist does a diagnosis, there is a feedback for the GP. If there is a need for some assistance by social care services, they also know about your situation. What is as well important, your family, your friends, neighbors, depending on your situation, and obviously based on your consent to share that information, they also know that you have an issue, that you might have need help, and so on and so forth. So in general, it's working together around patients or around people even. Now this term is more popular, people-centered care, to satisfy their to answer to their needs. And what is so important, it's not only about purely care needs or care problems or health problems. It's also about making their life going as it was before they got sick or close, similar to that. So
that's very helpful to give that overview. And it's interesting there that, Philippe, you say it's not necessarily just for non-communicable chronic conditions, but Joachim, I understand you did a study which looked at the changes of people's consumption of healthcare throughout the pandemic, and found indeed that it was those with the long-term health problems that had cut their use of healthcare services the most. So what are those implications then of those findings that you had, that pent-up need that must be there?
Yes, so we looked at healthcare other than COVID-19 healthcare, which is, of course, that was a huge change in healthcare, that they needed to switch and take care of those patients. And in order to do so, certain changes had to be made on the supply side of healthcare. And we could see quite clearly that the supply was cut more for people with long-term health conditions and people with complex care needs and so on. And so prioritization happened more to their healthcare than other people's healthcare. And in terms of numbers, it was about a quarter of people with long-term health conditions that were subjected to prioritization, that they got appointments canceled and so on. and compared to about 10% of the rest of the population. But it also affected the demand for healthcare, and a large proportion, more than half, I think around 55% of people with chronic conditions abstained from seeking healthcare or canceled appointments themselves and during the pandemic, and that was compared to a little bit less than 40% for the rest of the population. So we actually saw quite a big impact also on other people, but it was significantly more pronounced in people with chronic conditions.
And so, Joachim, just picking up from that, what are those implications then? There must be so much of a backlog of demand there.
Yes, so we see so we see a backlog in many different areas, and so the obvious one that is discussed the most, I think, is in terms of surgery that has been postponed or cancelled, and we see a very large number of operations that we need to catch up with, and it's very easy to look at those numbers, obviously, because you can it's a head count, you can count them very easily, but there are other more complex health needs that haven't been met. And another one, which is perhaps also quite obvious, is of course the screening of different kinds that has been postponed, and the health effects of that will be seen sometime in the future, different for different screening programs, obviously, but also in general for maintaining health in people with various risk factors. It's not as easy to quantify, but it will certainly have long-term effects, and it's important for the functioning of the healthcare system that you can help people with risk factors to stay healthy and not become patients because of those things. And so that's one effect, and maybe the most difficult one of them all is, of course, the psychological and social impact, which we studied in a separate project. So there will be long-term consequences also in those areas, obviously.
And that's really interesting. When we talk about integrated care, Philly, could you explain a little bit more about the concept of this horizontal and vertical integrated care, how that works? How should that best work? What's the difference?
So thank you. As I already mentioned, the cooperation between health and social care, so we call it horizontal. This is the cooperation, integration between two systems, different systems, even though they should work together. When we talk about vertical integration, it's the cooperation or integration within the health system. So starting from the basics, from primary care via secondary, tertiary, if it's needed. So these are the differences. Answering the question, how should they work? I mean, in theory, they should work smoothly. One of the terms is seamless care when we talk about integrated care. So obviously there should be, as I already mentioned, there should be a flow of information about patients. The patients should know, not only, first of all, know where they should seek help or assistance in specific situation. They should also have this possibility, because access to healthcare in terms of services being in the basket, I mean, legally available is one thing, but real access in geographical or monetary terms is something different. So this access, this real, I would call it real access, is very important. But it all boils down to flow of information, to cooperation between people and institutions. This is very important. There are cases where institutions do not cooperate, but people do. We can observe it in some localities, even if I don't want to say legally it's impossible, but even if there's something is not very strictly regulated, if people know each other in small rural communities, obviously they would be more willing to cooperate. I mean, the overall concept is still the same. We should share information. I'm repeating myself. I know it very well.
And in that sharing then of information, and what needs to be done, because across any healthcare system, there are inequalities within the systems, there are inequalities of access and treatments across the member states. So sharing of that information, as you put it there, Philippe, how important is that? What's going to enable that sharing, Philippe, in order to make that coordination and integration work more seamlessly?
As I said, people are the most important. So I would say that first is a mindset. We observe it in many health systems, for example, rising importance or more prominent role of nurses or pharmacists. So first of all, I don't want to be harsh towards doctors, but first of all, doctors should, for example, realize that nurses are their partners in providing care. So the times where nurse was an assistant to a doctor is a matter of past. So first of all, people should realize that other professionals in the system are their partners. Obviously, we need we need regulations, legal framework, especially since we are talking about very sensitive information about our health, about our private life. We need technology. Obviously, it's much easier to use internet, safe connections, etc., to send messages instead of sending traditional letters. So these are the three elements: the mindset, the regulations, all types of that, and technology.
Thank you. And what about financial incentives? Joachim, what would you say? How important might financial incentives be to drive greater efficiency across the systems?
Yeah, I think they're important, and in a very broad sense. We've spent a lot of time studying exactly these issues, and looking. The whole agency was in fact founded partly on basis of the observation that it's the gap between different levels and organizations that people fare the worst. And so it's I'm not going to contradict Philip, but I maybe want to nuance it a bit, because when we talk to, for example, healthcare workers and doctors and nurses and so on, and they know that they need to integrate with, say, social care or the schools or whatever. But when you talk to a doctor, they say things like, okay, yeah, I completely agree, and I'm going to have to talk to maybe the school nurse. But when am I supposed to do that? I have 1 hour of phone time every day, they say, and that whole 60 minutes is completely blocked every day of the week. When do you want me to talk to the school nurse? They say, I have every intention of doing so, and they also say the person that I'm supposed to talk to is equally busy with other things. So if it's, I think it's more than a mindset. I think they all realize that the outcome would be better for the patients. But so financial incentives is one part of this. And the leadership and the organizational structure and what's actually part of your job is, I think, so that's what I mean with a broad sense. It needs to actually be implemented as part of your job. And after having studied this for a long time now, my own conclusion is that it's usually, if you have to cooperate between different organizational levels, it's very likely that it will fail. In fact, I think in the current system, I think it's really risky. And the outcome is usually that people with strong resources that are highly educated and have high incomes and so on are often able to manage their contacts between different care levels quite efficiently together with people. But so the people who really suffer are the ones with socioeconomic that are disadvantaged socioeconomically in terms of education, language, income, and so on. And they are the ones who usually fall in between. And or if you have a cognitive impairment and things like that. So it's so you need, and the most successful examples we have seen here in Sweden is when you actually redesign the organization so that you have this, so that you have the different types of services within the same organization. And we have, sorry, yeah, it's just that because we have tried with financial incentives too, and it's really, really difficult to make it work. So it's, yeah.
The question,
sorry if I answered a different question, Sue.
It's very helpful to get an understanding of that.
Yeah.
Where you talk about the different roles of different healthcare professionals there, let's look at a question that's just come in. Thank you to Irina, who says, unfortunately now sometimes a doctor is not available. What kind of role can the pharmacist play in this situation? And Irina is the Vice President of International Diabetes Federation. Is that one for Joachim, or is that one for Philippe, or both of you? Roles of different healthcare professionals here. Joachim.
So I think that's also a question that we're looking into quite a lot in Sweden, and there is actually a government commission even looking at that particular question here. So it's an interesting concept, and but I think again, if it's you need to do much more than just recognize that they could do something important and change, talk about the mindset or the culture, because that will not get the sort of put the right incentives, broadly speaking, in place or make room for them to be a part of the system.
Well, if it means more than that, then perhaps if I could take it over to Philippe, is it means more than that? Philippe, if healthcare systems then are rather designed for acute care, they're based around primary care doctors, not long-term conditions. So perhaps is it time for Europe to have a strategy for non-communicable diseases? Would that focus this? Would that, and if so, what sort of components would you like to see in that, Philippe?
What do you mean by Europe? I mean, speaking on behalf of the Commission, the European Commission, I have to be very clear. It is not up to us to propose it. It is up to the member states to organize health systems. Obviously, from the point of view of the Commission, I mean, with our overview of the systems, we see a need for actions. But I want to be clear here, answering the question, saying, yes, there should be a better structured approach to chronic diseases. We are ready to help you, dear member states. I would put it like that. I'd like also to come back to that question about the pharmacist. I will answer with asking a question. First of all, probably Joachim also said a bit about that. First, we should ask a question: what does the doctor or do? I mean, obviously, if it's informing a patient, for example, about proper blood pressure, or interpreting the results of blood pressure measurement, if doctors does it, pharmacists can do it as well. No problems with that. There are countries that at least consider giving pharmacists a greater role in prescribing medicines. So even continuing pharmacotherapy initiated by a doctor or by a nurse. So this is another example of the role the pharmacist can play. Sometimes the pharmacist is helpful since is present in some rural or that kind of hardly or remote areas, hardly to get areas. The pharmacists can do also kind of prevention and promotion work. Now we observe it in many countries that pharmacists order COVID-19 vaccines, not only order them, but also qualify patients to vaccinations. So there is a room for maneuver, or there is a possibility for pharmacists to play more active role in health systems, especially that since the pharmacists, they say we are not only people educated to sell things. We are not shop assistants. We are health professionals. And naturally, it all depends on the country, on the situation in a specific country. But yeah, there are roles that pharmacists could play, no doubt about that.
Another point that's popped in on the Q&A, and thank you very much for submitting questions. Keep them coming. John Bowers says it's not just partnerships between healthcare professionals we need, important as they are. We also need close working between health and social care professionals, not least at the point of discharge from inpatient care and in support of self-management and all the opportunities that E and M health technologies are bringing. How do we achieve this? So there are, we've touched on technology, we've touched on data. Joachim, how could those help to bring integrated care together now that we've got an acceleration of the uptake of technology?
Yeah, no, that's an excellent point. And I think there are some, at least in our case in Sweden, we have significant legal problems with sharing data between these two sectors, which is a major issue actually. And we need, and there is work ongoing to change that. And it's actually interesting that we did a survey or quite extensive work with surveys and interviews in the general population and even patient populations, and about the trade-offs between using technology and sharing data and the safe and the safeguarding privacy. And everyone sort of assumed that data is already being shared. That was the most interesting finding. And when they realized that to what low extent it's actually being done, people were shocked, I think. So it's because they expect society to do this sort of basic information sharing for them, and it's not being done. And it's to a large extent a legal problem, and to some extent obviously also technical problems that you need to have interoperability between systems and so on. And then you also need to have incentives for someone to act on those, on the information that shows up. And there are things you can do. So we have changed, for example, the laws in how long the municipalities are allowed to wait before they bring home patients from hospitals. It's mostly elderly people that they like to live in the hospitals for as long as possible. And that's not because they shouldn't be in healthcare, they should be in the municipality social care. And that turned out to be possible to change with creating the right incentives, namely that you fine the municipalities if they let them stay for too long. So there are things you could that you can do, but I think a lot of it has to be done with you need to make sure that you have up-to-date laws, and you also need to make proper use of technology, and much more needs to be done in terms of, say, home monitoring and monitoring over distances. And I think not only pharmacists but pharmacies can be a great help here, and I think there's a lot we can learn from rural healthcare models where they have done quite a lot of that work. And I think there's a tremendous potential in that we haven't used yet in technology. And I would like, sorry.
Thank you. Before we just wrap up this part, I'd like to let Philippe have perhaps the last word. Javier, in his introduction, said that integrated care should be mandatory. And Joachim, you're saying that actually people are surprised that there isn't joined up care. Philippe, should this integrated care model be mandatory? Briefly, please.
No.
That was brief. I asked for brief.
No. There is a need for some controversy during the discussion. No, I think we shouldn't talk about mandatory integrated care. We should support developing it, but we should also remember that there are some cases. I mean, someone breaks a leg or cuts his or her finger, also needs some care, but then with leg, maybe it wasn't the best example, because sometimes there is need for aftercare. But with those acute problems, integration of care may not be needed. But I agree that there is a need for supporting integration of care, because even with COVID, which is a communicable disease, still the greatest burden is of non-communicable diseases. And apart from that, COVID showed that integrated care also is helpful. we started thinking about COVID as a pulmonary disease. Then it turned out that it also affects heart, nervous system, and so on and so forth. So even here, you see that there is a need for cooperation between different experts, different professionals. So there are many occasions for using integrated care, but I think we shouldn't impose it. It's better to convince people, and also if we make it mandatory, if we would make it mandatory, we would have to set limits, because as I said, not always there is a need for integrated care.
Thank you very much for that. Philippe, thank you very much. And also to Joachim, thank you very much. I'm about to introduce Ellie, but I do have a message from Javier, having quoted him there, asking to come in. So if Javier has his microphone on, have a quick a word to us, Javier, here, please. Are you still there?
Yeah, if somebody allow me to make the video on, or maybe not needed. Yeah, I thank you.
Just very briefly, please.
Thank you. I mean, I fully agree with what Christian said completely, but don't you think that it's a little frustrating that having a lot of data we have in many European countries, and thanks to this COVID crisis that put all the healthcare systems under a big pressure, we still are in so many inactions. There are not so many actions done. I mean, from the European perspective, I think there's important lessons to learn for the citizens' perspective, that we have big data, and in my opinion, it's unethical with all of these data not to provoke some movement in changes. So, I mean, instead of keeping on the plans, that is the former approach, we have to move to actions. And I think thanks to this action like today, we have to try to twist a little bit what is going on. But I mean, I expect from the politicians and for the authorities to be more brave in terms that we have data, everybody have data, and now it stems to do actions. And actions means that all the citizens at least receive a minimum attendance appropriate according what is under the evidence of the data we have available. And there's aspects that, and probably some lessons we learn also, that all of these crises makes a different aspects, the different settings, hospital, primary care settings, nurses, all were completely blocked, all completely with no connection with them. And we have data that we have to improve that thing. When I mention about integrative care, I would like to stress that aspect. And in the European Union, I think there are countries that are doing probably the work in a good way, in a good approach. Probably the others have to learn from that ones that have a good approach, because from European perspective, it's unethical if you are living in Latvia or in Finland or in Spain, the service you are receiving is different. So I think we have to reach at least a minimum approach thanks to the aspects we are observing at the moment. Because and I understand the point if it's not mandatory, but I think there is some kind of responsibility must to be on the table of the health authorities and all the politicians to change the systems.
Thank you, Javier. Thank you for clarifying that point. And thanks again to Philippe Domansky and Joachim Ramsberg. And of course, actions that should be taken need to be informed by evidence. Let's get some of that evidence. Specifically looking at the case of diabetes and how integrated care could bring value there. To bring us some latest analysis, I'm very pleased to introduce to you Ellie Vaughan. She's the Global Health Manager, Health Policy and Insights at The Economist Impact. So Ellie, you've got the research. What does it show? Over to you.
Thanks so much, Sue, and thanks everyone for really stimulating conversation so far. So we've heard about the impact of COVID on people with chronic conditions generally. So now I'm going to talk in particular about diabetes, because one of the things is that we see that chronic conditions are ripe for innovation in terms of integrated systems, but in particular diabetes, because when we think about this syndemic sort of crisis that we're facing, diabetes is a condition that not only coexists with other conditions, but also interacts with it. So it's something where it's very logical to want to introduce integrated care. And it's something where, you know, there's a lot of sort of imperatives there to do so. So I'm going to talk to you today about a scorecard that the Economist Impact put together that was supported by the FPIA Diabetes platform. So why do we need a scorecard looking at this? Well, as I say, it seems like a logical solution to the problem of rising numbers of people with diabetes, rising costs of managing diabetes, but it was something that we felt that there was a need to actually look at how well established integrated care was across Europe. So the scorecard that we put together looked at the EU nations and also the UK. And what we did was essentially to just take a sort of temperature check of what is in place currently, and then talked to interviewees about what could be in place in the future, how we could improve integrated care across Europe for diabetes. So the scorecard itself, I appreciate you can't actually see the detail of it here, I apologize, but I've got links to it later for you to follow up. We looked at two key domains that we identified through literature review, and that was the impact of diabetes. So that's on the left-hand side here in the sort of different shades of turquoise. And that was looking at things like diabetes prevalence, DALYs, expenditure, etc. And then the real kind of meat of the scorecard was on the right-hand side here, where we looked at the presence of enabling elements for integration. So firstly, we looked at evidence of integrated services. So were there things like clinical guidelines that helped to structure integrated services horizontally and vertically, as we've already heard about. But we also looked at some of the structural and sort of infrastructure elements that can help to enable integration. So we looked at health IT systems in particular and how well those were integrated. You know, is there interoperability between different systems? Can data flow across different systems to different teams? And then we also looked at aligned finances and responsibility. We've already heard about vertical integration, but here we were looking at, are the finances integrated? Is there a flow of money that helps, again, to incentivize, as we've heard about, but also support that integrated care? So just a note, this scorecard, we didn't score countries as such, because actually when we looked at the data that was emerging, we felt it was better to give a slightly more nuanced picture than just a sort of, 5 out of 6 or whatever. So you can see here that we've got sort of green, amber, and red. So that was countries were either yes, yes or no, or they were fully, partially, or not met. So that means that you can have a look at the scorecard and you can really easily see the countries that are doing better and the countries that have further to go in terms of integrated care. So what we found, our sort of top headline findings, were that there's good evidence of integrated diabetes policy across the countries that we looked at. So based on the policies that we looked at, there is quite a lot of integration in diabetes services. Now, I appreciate that the reality on the ground may not always reflect the aspirational elements sometimes of policy, but this was what we found in our research. And then where we started to see the sort of the inconsistencies emerge, and just having a look very broadly at the scorecard, you can see we've got lots of green here, and then the amber and the red start to creep in on the right-hand side. So in the IT systems, we only actually had 8 out of the 28 countries that received a full score. So there were a lot more gaps here. So a lot of countries had sort of interoperable electronic health records, for example, but we found that there were a lot of gaps in terms of diabetes registries. And we know that diabetes registries are really important repositories of information and enable us to understand what's happening on the ground in terms of outcomes and also the way that people are being managed, etc. And equally, we saw that aligned finances and incentives are also less well established parts of this integrated diabetes system, because only 7 countries scored fully out of the indicators in this domain, and 8 of the 28 countries didn't score at all in that domain. So that's really where that's quite a sort of gap in terms of how we're thinking about integrated services. So that's a very brief overview of the findings of the scorecard. But what I wanted to show you was also the calls to action that we came up with. So as I mentioned, we did the desk research to populate the scorecard, and we then went, we had an expert panel who advised us on the scorecard, and then we also did some interviews to understand some of the sort of implementation challenges that people will be facing. And several of the panel members on today's discussion were part of the project. So thank you to them for their invaluable input. So the three key calls to action that we came up with was firstly to engage people living with diabetes, to put them at the centre of integrated diabetes services. So to ensure that those are fit for purpose, but also are meeting the needs of people living with diabetes. And that harks back to something we heard earlier in terms of sort of patient-centred care and making sure that we're putting people with diabetes at the heart of what we're doing. We also suggested that there's need to align or pool budgets, because it's all very well and good saying that people should work together, and this is a great way to sort of reduce costs, to increase convenience for the patient, improve outcomes, etc. But actually, if the money doesn't flow and the money doesn't help to incentivize that way of working, that can be a major barrier to that change, because change is difficult to enact. We all know that. So we need to make it as easy as possible and as incentivized as possible. And then finally, we suggested that there's a need to establish evaluation mechanisms. So making sure that where we do implement these new types of services or these new ways of working, new ways of financing, different services, etc., we need to make sure that from the outset, we're measuring the impact of these services. Are they having an impact? Are they having the desired impact? So that's something that's really important, because it's not enough to just say, logically, this should be a solution and this should be helpful and it should work. We need to actually see evidence of that as well. So where can you find this work? So we have a digital hub that's dedicated to it, which is integrateddiabetessystems.eiu.com. And this presents the key findings of the scorecard. You can download the white paper and also the Excel workbook. And something I'll just draw your attention to, again, very small screenshots on your screen here, but we've got some really cool data visualization, which just allows you to explore the data in a bit more detail and enables you to sort of explore that for yourself a little bit more, not just our interpretations of it. We've got a white paper as well that you can download, and that gives the results and conclusions at a regional level, and also some really cool implementation case studies that you can look at, because as I mentioned, we know that policy is one thing, the reality on the ground can be another. And then finally, there's the Excel workbook, which is really the underlying heart of the scorecard itself. So here you can see all of the scores that we gave different countries, but you can also see the definitions for the indicators and the notes on our scoring decisions as well. And I should just say that this research did come out a little while ago, so answers, I would be very hopeful, might have changed and things might have improved and things like that. So just bear that in mind when you're looking at the data. So that's it from me, and I'm very happy to answer questions in the chat, in the Q&A, textually, or Sue, if there's time, you can always bring me into the discussion. But thank you very much for your attention, everyone.
Thank you very much, Ellie, for that very, very comprehensive show of the report that you've put together. That's really, really powerful. And thank you for staying on. If questions do come up, do submit questions. We're going to go into a second panel now, but we're very much hoping that this has sparked thoughts, questions, and we very much want to hear from you, the audience. But let's get on to our next panel. And I'd like each of them actually just to say who they are, because they each bring a different expertise. Professor Angus Forbes, who are you, and briefly, what do you do?
Blimey, who am I? That's an interesting question. I'm Professor of Diabetes Nursing at King's College London. I'm a clinical academic researcher. I see patients clinically, but also do a lot of research, mainly in the area of psychoeducational development to support and prevent psychological distress in people with diabetes. But I've also been recently chairing the EDF's work stream on integrated care. So I feel like I'm kind of quite versed now in quite a lot of these complex discussions around this. So hopefully I can contribute something to our little chat this morning.
That's lovely. Dr. Nitty Paul, who are you? What do you do?
Hi, good morning, everybody. It's lovely to be here today, and thank you, Sue, for allowing us to introduce ourselves. I'm a primary care doctor by trade, a GP in the UK. I wear 3 hats. I'm, well, 3 or 4 hats. I'm here today as the president of IDF Europe, and I've also been sitting, like Angus, on this working group. I also work for KPMG as medical director for a global healthcare practice on universal healthcare, and I worked in many countries, including low and middle income countries across the world. I work for AXA as a senior digital health advisor, and I work for Harbour, which is a tech accelerator incubator in the UK. And my passion is affordable, accessible healthcare. My world with diabetes has been advocacy for the last 27 years. My son has type 1 diabetes and has had it for 27 years.
Gosh, thank you. That's very, very helpful. Maysa Booyah, who are you? What do you do?
Hi, Sue. Hi, everyone. It's my pleasure to be here today and discuss this important topic. I am a head of medical global franchise at Sanofi, where I'm in charge of several therapy areas, including diabetes. But here I'm on behalf of FPA Diabetes Platform, and together with Angus and Nitty, I am part of the important, I would say, strategic forum discussing integrated care for the last many months. So happy to participate in discussion.
Thank you. And Dr. Javier Cost is joining us on this. But do we have you there, Javier? Yes, we do. Just briefly, do you want to say hello again?
Hi, everybody. Thank you again for being involved in this panel, and just been delighted to be participating in the discussions. Thank you.
Lovely. So let's kick off. Angus, you were saying there about the psychological aspect that you focus on. And I understand you run motivational enhancement clinics. How do you think then that those aspects, the psychological, the social, the emotional, can be integrated when people have diabetes, and the integrated care needs to consider this?
Oh, that's a very good question. I think it has to be, so a lot of diabetes is about behavior, so it's what people do ultimately that will affect whether or not they get complications of diabetes. Living with diabetes has multiple psychological, social, and other consequences that can get in the way of those behaviors occurring. 99.9% of diabetes is self-management. So unless we enable people to feel that they have an understanding and an awareness, and that they are able to process out some of the experiences that are getting in the way of those behaviors, then it would be very difficult to to run any kind of level of effective diabetes service, in my opinion. And this is where I think some of the issues around integration kind of break down, because not only is it about the way that we organize services, it's how we deliver them. And it's the philosophy of care which underpins what we do. Going on and listening to the previous debate a bit about that, we have to realize that health professionals are also emotional beings, and that much of what is happening and the discussions about integration are to do with behavior. My message into this discussion really is that if we want to address integration, then you have to kind of consider what drives human behavior. And I think that underpinning some of the challenges in integration, on the top level rational perspective, integration is a no-brainer. Let's all work together, make it all harmonious, and it'll all be perfect. In reality, it doesn't happen. And why is that? And that's because people don't really see or value or identify benefits for themselves in doing that. And that's at all levels, the politicians right through down to the clinicians. And also relevant to that is obviously how we interact with patients, which is what I'm interested in.
Thank you. Well, one of the things that does motivate human beings is money, financial incentives to human beings, to systems, to organizations. And Niti, you have an amazing overview working in the UK, but having worked with the global perspective. What would you say are the best reimbursement systems, the best financial incentives to try to bring integrated care into a reality?
That's a good question too. And that's the holy grail, right? People are motivated by all sorts of things, but money in systems is also very important. And money should follow the patient, but that doesn't often happen. So one of the systems that I'm a great fan of is Clalit in Israel, part of the European IDF family. A huge, a well-kept secret. And some stuff, Javier, you'll have a sight of this as well. In Spain, Ribera Salud, Sanitas Manisas, the system in Valencia, some really interesting models of what I call accountable care. And you could flip between accountable care and integrated care depending on where your mood takes you for the day. And in Clalit, the things that really matter, and we at KPMG also look at some of this, so I don't want to be banging that drum. But the biggest feature of that is that the money follows the patient. There is no purchaser-provider split. There is a purchaser, that's the government, the Ministry of Finance or the Ministry of Health, but then internally there's no purchaser-provider split, and the money is bundled. It's very clear what the financial envelope is for that care, and every provider in the system knows what that money is. So they stay within that bundle and within that thing. And of course, what also happens is the right care in the right place, so it costs less. So 20% more community and primary care interactions happen in Clalit than in the UK. So care truly has moved out into the community, and also the workforce has moved out into the community. And then finally, the thing that really enables all of this to happen is technology. And we've seen quite a lot of that across the world as we went into the pandemic, and systems that were able to respond with technology for patients that made it easier for patients to navigate between the click, which was the digital services, to the brick, which is it's a term I coined during the pandemic. So that seamless transaction between the click and the brick that allowed that to happen, for the patient to own their data and for that data to be across both, is what allowed this. So the huge investment in tech happened in Clalit about 20 years ago, and it's continued. Ribera Salud is the same in Spain and Valencia, they did the same. So it's population health management at a higher level, passed down at every level, and patients are co-designers in their care and the services that they want to see. And that's kind of what we want to see from IDF Europe's perspective. I'll stop there.
So thank you. And so as you explain then the efficiencies that come in that, Maya, what about those health economic benefits then, the actual value for money that a better integrated system could deliver? Maya,
Sorry, Sue, could you please repeat? What is the economic benefits?
Yes, what Niti describes there about the efficiencies that the best financial system could deliver is going to then bring a health economic benefit to the overall system, better value for money if healthcare systems can take up integrated care. Is that how you see it?
Absolutely. I don't think I need to elaborate more on this point, since we know that ultimately, if the patients are better managed, if the physicians do have opportunity to get appropriate incentives for what they do, incentives, they don't need to be only monetary incentives, as we discussed in our working group as part of EUDF discussions. This will translate into ultimate better health outcomes and better economic benefits for sure.
And so in evaluating that then, Maya, what sort of evaluation systems are needed in order to prove that point?
Well, absolutely. Without monitoring of the impact of the interventions, we don't know what, what we are doing is right. So we can start from data registries, right? That we heard that only few countries, maybe I think 15 countries in Europe, have data registries. So if we have a data where we are measuring not only A1C, but all other health outcomes, we can definitely see how this works. And I believe also in Bulgaria, there is an example of a registry where the governments are really providing rewards based on the patient outcomes driven by the decisions, different decisions throughout the process.
Thank you. And Javier, let's bring you back in here. We've talked then about putting the patient at the heart of all this, patient centricity. We hear about, but what does that then mean? What sort of communication with diabetes patients could be improved to make this all work much better?
I think that has been said by my colleague Angus before. I think is, take time to hear what is the patient thinking and the families together, and then make a good diagnosis, a good prognosis. What are the needs? What are they expecting? And then according to that, and also the complexity of that situation. In what situation is the patient? You have to establish and agree a plan with the patient, a shared plan with him and with her and with the families. And according to that, you're going to offer moving to different resources into the system, nurses or healthcare assistants or pharmacists, whatever you have available, but also with the idea to make the person living with diabetes responsible and coaching him to have the control of the disease. The person is living with a chronic condition, is not living for the chronic condition, is living with a chronic condition. And then we have to try to improve as much as possible the quality of life. I'm providing service in diabetes every week. I have complex patients in my list, and I try to follow that approach. When I have a complex patient that it has been referred to the unit to me, I try to dedicate half an hour speaking, seeing what's going on, what are the expectancies, what are the barriers, what are the thoughts, what are the threats, whatever. And then from that point, start building together with the person and seeing what is feasible, what's possible, what must be the next points, the next steps, and then not be hurrying, not blaming, just because that persons are all the time feel blame. They feel guilty. They feel like with a chronic disease, they are living for the chronic disease. No, we have to they are human beings. They are persons living with a chronic condition. And also it's really crucial. And we know from a study, the Down study, that for them is crucial the involvement of their families, of their relatives. And I think also it's a crucial thing. I also ask the person to come with a relative to the contact, if possible. I try to involve technologies. I ask for make photos of the dishes, of the plates they are preparing, how the things, just to keep more human, to be more connected. And then persons feel more breaking barriers and more open to changes and more open to be adhere to adjustments, to new aspects. And I think this is probably a perspective we have to consider, because sometimes healthcare professionals, we are very aligned with medical things, but not really, we are not moving comfortable in these emotions, in these aspects that are probably the crucial aspects for a person living with diabetes.
Thank you. And Angus, then that's very much an area you work in. And you said, I was amazed by that statistics, 99.9% of diabetes then down to self-management. And from what Javier was saying there, and don't blame people, but what about prevention? If prevention could be such a key principle then of integrated care?
Oh, it's essential. So one of my big things is that we strive to prevent diabetes complications in the physical domain, but we underestimate and we don't really strive to prevent psychological sequelae of diabetes, which actually then we start dealing with it once they've got, fairly profound psychopathology, which I think is a bit bonkers. But just to pick up, I think that Xavier made some great points there. And what I would like to sort of say really is that integration really needs mission alignment, so if at the end of the day you've got the clinician who sees a patient in front of them is trying to do something that's not what the patient is wanting to receive, then that creates failure. If at the end of the day the person who's counting the money is just purely concerned about balancing the books and doesn't have a sense of vision about how the patient's experiencing care, that's going to create failure. All the examples that Niti gave, which are brilliant examples, have emerged from the primordial soup of people really thinking about what is important and how can we do things better. What's missing is how do we generalize that into, so that everybody has that kind of way of thinking. And my view, and this is some of the work that came out of the forum, is that a key change that needs to be made. This is not in the curriculum for the education of healthcare professionals. We don't teach them how to think differently about the world and how to look at it more than just the patient and how to treat the patient. We need to tell them about these other things, including how to interact with patients, but also how to work the system in a much more progressive way and how to learn from it. Because the one thing about integration is integration has its moment, and what will have to happen is it needs to continually evolve. And the only way that can evolve, that has to be driven by people who have the ability to think and see it for what it is, you know, and to identify the benefits of it. So I personally think that one of the big shifts that need to take place if we want to kind of generalize integration. I mean, Nitty made some great examples of what's happening in various countries, some of whom have got very little economic resources. I mean, I visited Palestine, you mentioned Israel, but they were embarrassed about what they're doing, but actually I was very impressed because the necessity is the mother of invention. And that's the same with the COVID crisis. It tips things upside down and people have to think differently. It happened after the Black Death. It's happening a little bit now with COVID. But unfortunately, we don't have the collective mind to kind of see that. And I think that's a missed opportunity. And hopefully that we will begin to kind of identify how we teach young health professionals and those working in administration, other things, to work in a more harmonized way about how they think about these systemic problems.
Thank you. And I would welcome more questions coming in or anything from anybody who is living with diabetes. If you're listening to this, do join us. But Nitty, come back, pick up on those points. We wanted, in the Economist Intelligence Unit report, they talked about not having the top down, the bottom up, putting the patient there, learning from the patient, as Angus was saying there. How could that shift happen to get to the best practices that you described?
So, I mean, the best systems in the world that actually do this do use patients as co-designers. So that's kind of the first thing. So clearly it are very much led by a very single board, but they're also led by patients as co-designers from the bottom up that you're talking about. And I'd just like to just bring us back to talk about that. So at IDF Europe, we're very keen to get that voice back on the table, because often healthcare systems and doctors and nurses are so busy doing the doing, and they're very busy doing the doing, seeing patients, 50 patients. I used to see 50 patients a day. You just don't have the time to lift your head up and to do the other stuff. So it's really important that we actually take the time. And I'll tell you a little story from my days in general practice in inner city Birmingham, where 33 different languages were spoken in my practice. And I started doing structured diabetes education for a group of Asian patients, of Asian ladies. Some of them had never stepped outside the house before. They spoke 3 different languages. I only spoke 2 of them. And I did this led by lay health workers. And I was told at that time by the National Clinical Director for Diabetes that was not allowed. I would not be paid for getting lay health workers to do structured diabetes education. It was quite a story. Well, I got the National Clinical Director, you'll guess who it is, Angus. I got her down to my practice in Smethwick in inner city Birmingham. I said, why don't you just talk to my patients? Just talk to these guys who've been through this structured diabetes education program. And she did. And she was challenged in Punjabi by a couple of my patients who said, why haven't you given this to us before? It's the first time I know how to deal with my diabetes, how to deal with my husband's diabetes or my kids' diabetes. It's the first time you've taught me this in my language. It's the first time you've talked about Asian foods. Why has the NHS not offered this to me before? And that was the turning point for the National Clinical Director for Diabetes. And then we got structured diabetes education that was allowed to be given by lay health educators. These were peer-supported, peer educators, far better at giving education than I ever could have been. They were far more able to say to each other what should be done and what shouldn't be done. So that's a story to be told for us to learn from. Taught me a lot about how I approached the powers that be, and how you look at some of the finances as well. And then on the other side, I've spent my entire life as I've been PCT chair, I've done CCGs, I've done the lot. I've got the T-shirt, and I'm wandering around the world doing what I'm doing. Again, from that perspective, if you do not talk to patients and the open APS community, the diabetes world will understand this and they will know this. This is a community of type 1s These are people with no pancreas, so they don't have no beta cells. They have no insulin in their bodies. This is not preventable. And a large group of my son has that. Type 1 diabetes. This is a group of patients that are teaching each other how to loop their pump and their continuous glucose monitoring system. This was done by patients, not by doctors. And the hashtag that they use is "we are not waiting." So they're not waiting for us to do this. There's about 600 of them across Europe that are teaching each other to loop their pumps and their CGMS. They've created their own artificial closed loop pancreas. So here we are. Patients are even finding their own solutions for their care, fairly high-tech solutions for their care that doctors and nurses and scientists haven't found.
That's amazing. Well, Maya, you come from the industry perspective on this. We usually look to industry for our solutions, but hey, they're coming from the ground up. What do you make of that? What role is there for stakeholders like industry, but other stakeholders then to make better solutions?
You're on mute.
Yes.
Sorry, I had some background noise. I muted myself before. I mean, this is very, very inspiring what Niti is saying. And we cannot work as individual stakeholders, but we really need to come together, everybody, you know, HCPs, governments, you know, European Commissioner, patients, tech companies to really bring value for the patient. So this is a fantastic example that Niti just mentioned, how we should all be around the table and contribute to the success of the different initiatives. I mean, on a pharma side, we can definitely be there to bring solutions either on helping building the registries or bringing innovative therapies, bringing, I don't know, different educational programs, whatever can we do, we are definitely happy to do so. So in FPIA, for many years, FPIA Diabetes Platform, we are working, you know, together on how we can really improve lives of people with diabetes. So thank you very much, Niti, for your quite inspirational talk.
Thank you. And in addition to this panel, I see that we still have Philippe Domensky lurking in the background. If you want to join us here, Philippe, because it would be quite interesting. Javier came back on the point that we'd put earlier, but it would be very interesting hearing this discussion to know from a European Commission perspective about hearing about what different stakeholders need to bring to this to work together. And perhaps if you wanted to have the opportunity to pick up on what Javier had said earlier, what's your take on how the stakeholders need to come together here, Philippe?
Thank you. So starting with what Javier said, I already replied in the chat about the actions that we as the Commission finance, promote, which is sharing knowledge, experience about integrated care. Talking about the making together or bringing together different stakeholders, I wouldn't be probably very innovative in saying that since integrated care, as we already discussed, is about people, we have to have patients on board, which is obvious, especially in case of chronic diseases, because the chronic patients are the experts on their diseases. They know the best what outcome they would like to achieve. Obviously, not always know how to achieve it, but they know what they need. We have to have health professionals. It's crucial as well. We have to have policymakers and politicians. I would make a distinction between those two, because as we discussed, for example, financial incentives may work, and it is up to policymakers and to politicians to do so. We have to have technical people to provide us with tools, and then it is once again also up to a specific country how legislation or how strategies, that kind of documents are prepared, but for sure none of those communities should be outside. and the industry and the producers of medicines, but also the industry that produces some other solutions, I mean devices, depending on specific disease, specific health problems, should be on board as well. I know that I'm not very innovative in what I'm saying. I'm just confirming that there is a need for cooperation.
Thank you, Philippe. And Javier, what do you make of that? Does that satisfy you that they're the ones who should be driving? Who would you like to see most driving this, Javier?
I think that everybody must to be very aligned. I think that we have plenty of data because majority of countries in the EU have access to have electronic clinical records, and that allow us to have a lot of data of our citizens. And that I think we have to try to be using that data properly to try to see what are the best systems, how we can benchmark across countries, how we have to be probably more innovative, transforming the healthcare systems, which one is the best approach possible according to the tools you have available in your setting. Probably it's not the same scenario in some regions of my same country that in the other countries. We have a lot of difficulties to have GPs or some professionals at the moment. That is going to be worse in the next years. How we are going to be prepared for that? How are we going to introduce new roles in the healthcare system? How are we going to, I think this is questions we have now on the table, and we have to look for what are the best approaches, and probably other countries, other regions are doing innovative ways to provide care in that way. Probably always putting the person in the center, but we have to move to a more high value care context to try to diminish as much as possible those contacts that are poor contracts, low value, and probably reacting according to complexity. Sometimes we are, in terms of being of equity, I think of a misunderstanding of equity. We are trying to provide equal service for everybody, but I think you have to provide service according to the complexity of that person, emotionally, or I mean, in terms of complications, whatever. And I think that it means that all the persons involved in the healthcare system must to be talking, aligned, building a new agenda, because I think what it has been done, the COVID-19 is like a tsunami, it's an earthquake. Everybody now knows they have to transform, they have to change, and it's not time to move back to what happens in 2019. That will be a completely disaster. I mean, we have now in the position to change. We know for human beings how complex it's to change. We move in a kind of inertia. We feel comfortable in the same track. We have to change the track. And to change the track is that the approach we have to follow.
Thank you, Javier. Your energy is amazing. Niti, I just want you to have perhaps the final word from this panel, maybe picking up on that, but also just responding. Anne Felton has made a point and put in the queue question about, we've been talking about the EU, but how can we better work with the World Health Organization, Europe, in the context of diabetes? In fact, you have a more global view. Last word to you on this panel, just as a quick upsum, Niti.
Just a quick one on data. And you cannot have integrated care without data. Javier is correct, but the data is the patients. It's not the healthcare systems. Just remember that the data should follow the patient. Lots of stories to tell you around that. And in countries that are the low and middle income countries that I'm working in, there's lots to learn from them. So we're looking at new digital therapeutic solutions that are meeting patients where they are. WhatsApp, Line, Facebook Messenger, not new apps that you're downloading, because people don't download apps and remain on them forever, but really meeting people with digital therapeutics on platforms they're already on. So really starting to understand where consumers of healthcare are currently, and lots to learn from low and middle income countries. I'd urge us to look that end if we're looking for new technology, kind of digital therapeutics that are low cost. And we need them too in Europe, and the regulation around that. So that's my plea to Philippe and to others is to look at the regulation quickly. Let's not sit on our hands on the regulation. So that's one point. On the global view on WHO and other institutions, Anne Felton is entirely correct. She always is. Anne, hi, thank you for being here on this call today, on this webinar. We are working, IDF Europe is working very closely with WHO Europe. They've got a diabetes compact they're bringing out, and we're working very closely with them and we are the patient voice that is bringing that to the table. but there are other institutions across Europe, not just the EU. There's the Council of Europe. There are the Balkan countries. There are countries on the east that we often forget. That's the whole of Europe. It's not just the EU. So we at IDF Europe make sure we have advocacy in place across all the regions, not just across EU.
Neetu, thank you for that. And thank you for all of the contributions from our panelists. Thank you for the questions. I'm Sue Saville, and it's been my great pleasure to guide these discussions and now to hand over to Maya Bobonovic for her closing and concluding thoughts. Maya.
Thank you very much, Sue. I would like to thank all the panelists. It has been really great discussion. Difficult to summarize in few minutes, but let's say I will give it a try, and then if there is anyone who would like to add, feel free. First, I believe that we have all the ingredients for the comprehensive solution. A lot has been done. We know what works, we know what it doesn't work. We understand the barriers. We agreed that we need to join forces with broad coalition of stakeholders. We agreed that we need to foster the sharing of best practices. And we also agreed that in addition to all the efforts that could or should be done at the European level, national decision makers are critical for implementation. We agreed that integrated care is central to improving the quality of diabetes care. Mandatory, not mandatory, maybe not completely aligned, but I would say we all agree it's central to improving the quality of diabetes care. However, we also agree that there are several prerequisites for successful integrated care, and these were discussed at length, starting from unlocking the full potential of data, empowering patients, so putting patients in the center, a lot of emphasis on patients' co-creation through education, digital technologies, innovative therapies. We heard about numerous digital tools that are developed or used. It's important to share experiences from these tools around Europe. But we should not forget that we need to work on development of digital skills for HCPs and people with diabetes, because we cannot assume that if there is a new digital solution that it will be embraced by not so young population, either on the HCP side or on the patient side. And last but not least, rethink our health system. We heard from Philippe that the European Commission should develop a policy framework or help member states to map and define effective models of diabetes care and management. But basically, a lot needs to be done at the ground level by member states. Support scaling of digital services infrastructure has been also highlighted as important, and we understand that primary care should play a central role in integration of care for people with diabetes, with appropriate training, financing, and incentives.
Maya, thank you very much indeed. It was lovely to get that summary. There's so many points there you've covered, and the discussions could go on, but for now, thank you. Thank you to everybody, and goodbye for now.
Thank you very much. Bye. Have a nice day.
Bye-bye. Thank you.
Thank you. Bye-bye.